Right, so let's finish up the chapter 25, the urinary system, and we'll talk about transport, storage, and getting rid of urine. So the ureters are slender tubes that convey the urine from the kidneys to the bladder. They start at about L2, and they are a continuation of the renal pelvis. They are retroperitoneal. They will enter the base of the bladder through the posterior wall. And as bladder pressure increases, the distal ends of the ureters will close, and that prevents backflow of urine. 3 layers to the uteral wall from inside to out. We have mucosa, which is transitional epithelium, muscularis, which is smooth muscle sheets that contract in response to stretch. That helps propel urine into the bladder. Gravity alone is not enough. It must also be pushed. So there are peristaltic waves of smooth muscle. The rate of peristalsis can be adjusted to the rate of urine formation. There are also sympathetic and parasympathetic innervated ureters, but they play an insignificant role in the peristalsis. And on the outermost region, we have adventitia, fibrous connective tissue. Here's a microscopic cross-section of a ureter. Renal caliculi are kidney stones in the renal pelvis. They can be crystallized calcium, magnesium, or uric acid. Large stones can block ureters, obstructing urine flow, and that causes excruciating pain from the side to the abdomen. Nephrolithices are calculi in the kidneys. If they're in the ureters, they are uterolithicis. Some small caliculi pass without intervention, but larger ones or those lodged in a ureter can be removed endoscopically or surgically. Many kidney caliculi can be treated with lithotripsy, which is a procedure that uses acoustic waves to break the stones up so they pass more easily. Risks for caliculi are obesity and elevated blood calcium levels, and adequate hydration will help prevent kidney stones. From there we go to the urinary bladder. It is a muscular sac for the temporary storage of urine. It is retroperitoneal. It sits on the floor of the pelvic floor posterior to the pubic symphysis. In males, the prostate is inferior to the bladder neck. In females, it is anterior to the vagina and the uterus. It has openings for the ureters and the urethra, 2 for the ureters, 1 for the urethra, which form a triangle called the trigone, which is a smooth area outlined by those openings, and that's important clinically because this is a location that infections tend to persist in. The bladder wall is made up of mucosa, which again is transitional epithelium, a muscular layer, which has a thick detrusor muscle that contains 3 layers of smooth muscle, inner and outer longitudinal layers with a circular middle layer, and it has fibrous adventitia, except on the superior surface it's covered by peritoneum. Here is the male and female. The urinary bladder storage capacity, it's collapsed when it's empty, and when that is, you'll see folds inside called rugae. It expands and rises superiorly during the filling without a significant rise in internal pressure. Moderately full bladder is about 12 centimeters long, about 5 inches. It can hold about half a liter, 500 mLs, a pint for Americans. But it can hold twice that amount if necessary, but it can burst if it is over-distended. Here is a pyelogram, an image of kidneys, ureters, and bladder. The urethra is a muscular tube that drains the urinary bladder. Its lining is epithelium, mostly pseudostratified columnar epithelium, except near the bladder is transitional, and stratified squamous epithelium near the external urethral orifice. There are sphincters, an internal urethral sphincter, which is involuntary, made of smooth muscle at the bladder-urethra junction that contracts to open. And the external urethral sphincter is a voluntary skeletal muscle, surrounding the urethra as it passes through the pelvic floor. The female urethra is about 3 to 4 centimeters long. It's tightly bound to the anterior vaginal wall. Its external urethral orifice is the anterior to the vaginal opening, posterior to the clitoris. And the male urethra carries semen and urine, and it is named for 3 different regions, or divided into 3 different regions. There is the prostatic urethra, which is about 2.5 centimeters within the prostate. That's about an inch. The intermediate part of the urethra, or the membranous urethra, is about 2 centimeters. It passes through the urogenital diaphragm from the prostate to the beginning of the penis. And then the spongy urethra, which is approximately 15 centimeters, passes through the penis, opens through the external urethral orifice. Male, female. Urinary tract infections can be caused by improper toilet habits, such as wiping back to front after defecation. Short urethra females can allow fecal bacteria to easily enter the urethra. Most UTIs occur in sexually active women. About 40% of women get urinary tract infections. Intercourse drives bacteria from the vagina and the external genital regions toward the bladder, and the use of spermicides can actually magnify that problem. Urethritis is an inflammation of the urethra. Cystitis is an inflammation of the bladder. Pyelitis or pyelonephritis is an inflammation of the kidneys. These all have symptoms of dysuria, painful urination, urinary urgency and frequency, fever, sometimes cloudy or blood-tinged urine, and back pain if the kidneys are involved. Antibiotics do work on most urinary tract infections. Micturition is also called urination or voiding, and it involves 3 simultaneous events: contraction of the detrusor muscle by the autonomic nervous system, opening of the internal urethral sphincter by the autonomic nervous system, and opening of the external urethral sphincter by the somatic nervous system. Reflexive urination occurs in infants. It's the distension of the bladder activates stretch receptors that causes the excitation of the parasympathetic neurons in the reflex center, the sacral region of the spinal cord. That leads to contraction of the detrusor and opening of the internal sphincter, and they inhibit the somatic pathways to the external sphincter, and it relaxes to open. Pontine control centers mature an average around age 2 or 3. Pontine storage center will inhibit micturition. It does so by inhibiting the parasympathetic pathways and exciting sympathetic and somatic efferent pathways. And the Pontine micturition center promotes micturition by exciting parasympathetic pathways and inhibiting sympathetic and somatic efferent pathways. Here is a flowchart for control of micturition, and I encourage you to look that over in your text, figure 25.24. Urinary incontinence in adults is usually caused by weakened pelvic muscles. Stress incontinence leads increased intra-abdominal pressure will force the urine through the external sphincter. That can happen when you laugh, cough, or sneeze. Overflow incontinence happens when urine dribbles out when the bladder overfills. Urinary retention, the bladder is unable to expel urine. This can be a common effect of general anesthesia, which is why one of the reasons they keep you in the post-op until you have gone to the bathroom. It can also be because of hypertrophy of the prostate, which is an overgrowing growth of the prostate, and this has to be treated with catheterization, the sticking of a tube into the bladder. Developmentally, there are 3 sets of embryonic kidneys that form in succession. The pronephron degenerates, but the pronephrotic ducts will persist. The mesonephrons claim the ducts and become mesonephric duct, and the metanephros develop by week 5, and that develops into adult kidney and then ascends, goes up. Metanephros develop as uretic buds that induce mesoderm of the urogenital ridge to form nephrons. The distal end of the uretic buds form the renal pelvis, calyces, and collecting ducts. Uretic ducts are the proximal ends that will become the ureters. Kidneys begin to excrete urine into the amniotic fluid by the third month. The cloaca will then subdivide into the rectum, the anal canal, and the urogenital sinus. Three common congenital abnormalities include the horseshoe kidney, in which two kidneys fuse across the midline, forming a single U-shaped kidney that is usually asymptomatic. Hypospadias is a urethral orifice located on the ventral surface of the penis that has to be corrected surgically at approximately 1 year of age. And polycystic kidney disease, patients have many fluid-filled cysts that interfere with the function of the kidneys. There are a number of genetic reasons for this. The autosomal dominant, so only one copy of the gene is needed, unfortunately is the most common, but it is the least severe. Autosomal recessive, you have two bad copies of that gene, is more severe. And all of these can be caused by a defect in signaling proteins, we believe. Frequent micturition in infants is due to small bladders and less concentrated urine. Incontinence is normal in infants. The control of voluntary urethral sphincter will develop with the nervous system. E. coli account for about 80% of all UTIs. Untreated childhood streptococcal infections can cause long-term renal damage, and sexually transmitted diseases can also inflame the urinary tract. Most older people have abnormal kidneys histologically. The kidneys begin to shrink, nephrons decrease in size and number, tubule cells become less efficient. By age 80, the glomerular filtration rate is about half that of a young adult, and a lot of that may be from arterial sclerosis of the renal arteries. Loss of bladder tone can also cause nocturia, which are frequent trips to urinate at night, and incontinence. And I will be posting information about the final later this week.